Okay, everyone, maybe we can start, and then hopefully people will be able to join us as they come. We definitely had a good response in terms of registration. I see people starting to introduce themselves on the chat window. If everyone can continue, that would be great. Perhaps I can start now. I'm Andy Kendall. I'm the TechRRT Program Manager, and I will be facilitating the webinar today. Just before we start, if you can just make sure that your audio is switched off and your video is switched off, it's on the bottom right-hand corner of your screen. And welcome everyone to the webinar. First, I just want to go through what we'll be talking about today. First, it's an introduction. First, just go through an introduction to the webinar, which, as we've seen, it's Synergies in integration with IYCF-E. It's breaking down sectoral boundaries. I'm going to give a very, very quick overview of what the TechRRT is, just so that you have an idea of who we are and why we're interested to host this webinar. Then we'll be hearing the presentations from our guests. We have 3 presenters, and I'll talk a little bit more about them in a minute. We'll have a quick wrap up, and then we'll have some questions and answers and an open discussion. Just before I go on, I see we've had 3 people introduce themselves on the in the chat window. If I haven't had a chance to present yourself, you go to the right-hand side of the screen, the second button down, it's for chat. And if you click on there, and we'll be writing, if you want to ask questions during the webinar, you can write them there. But for the moment, if you can just introduce yourself, it'd be nice to hear who we have on the call and where you're from, so that we can have an idea of who's interested in the topic. Okay, next slide, please. Okay, so the webinar objectives. The first objective, we'd like to advocate for strategic approaches that lead to synergies among interventions and across sectors for optimal infant and young child feeding at all times, not just during emergencies, but during an emergency, it's even more important that this takes place. And so we'd like to emphasize that. Next objective. We'd like to share the idea is that we've been talking about integration of IYCF with other sectors for several years, and it's very clear. I think everyone knows that infant and young child feeding programming, both in emergencies and not, is really important, and everybody wants to bring it into programming. But the reality is that it's not really happening, and it's happening a lot less than we'd hope. And where it is happening, it tends to be piecemeal. So what we would like to be able to do is share some innovations and initiatives that are taking place, share some lessons learned and some of the barriers so that we can talk about why it's not actually happening, on how to integrate IYCF interventions throughout sectors. Let's just say it's as we talk about gender and it being mainstreamed, perhaps we need to be talking about IYCF-E and mainstreaming it as well. The last objective is really to raise the visibility on IYCF-E in the humanitarian sector, not just in nutrition, but across the sectors, across the humanitarian sector. Next. Okay. Oh wait, sorry, can you go back 1 second? So the World Breastfeeding Week on the website, they actually have lots of things that are very inspiring. One of the things that was really relevant for us today is alone we can do so little, but together we can do so much. And this was said by Helen Keller. This is an inspirational message for us, although I'm probably preaching to the choir with the people that are joining today, but that it's really important for us to work together to figure out how we can have the synergies that make a difference to women and children in countries that are experiencing emergencies. Okay, next slide, please. Okay, I'm the facilitator, as I said. My name is Andy Kendall. I'm the TechRRT Program Manager. We have three presenters today. The first one is Dr. Shogo Kubota. He's a technical officer from WHO Lao. He's going to be speaking on integration with maternal and child health. Our next presenter is going to be Erin McCluskey-Rebelo. She's a nutrition consultant speaking on integration and WASH. I'm going to tell you a little bit more about each of them just before we go into each of their presentations. Then the last one we have speaking is Alessandro Llamo. He's a TechRRT IYCF advisor. He's new to us. He's only been with us for a short time, but we are so happy to have him because he's extremely passionate in IYCF-E and IYCF, and he's going to be broadly speaking on integration with other sectors. I apologize. Instead of waiting till later, I'm going to tell you about each of them now. Dr. Shogo Kubota, he's a pediatrician who's worked in emergency medical relief through ICRC and Japanese Red Cross before joining WHO. He's currently leading maternal and child health team in WHO country office in Laos, People's Democratic Republic. He's been working on enhancing synergies and integration across different areas, as well as between programs and health system strengthening. Hang on, I think that the slides might be slow. Sorry, just to ask technically, are you guys seeing the current slide we're on before going to the TechRRT? Yeah, about the presenters. Okay. Now to tell a little bit about Erin McCluskey-Rebelo, she's a public health nutritionist. She's had 14 years of experience in many different countries between Democratic Republic of Congo, Tajikistan, Kenya, Somalia, and in general across the larger Eastern Southern Africa region. She worked with UNICEF Somalia for quite a long time and was specifically focusing on infant and young child feeding. She's recently done work on Synergized WASH and nutrition programming, working on the Toolkit for UNICEF SRO with the Center for Humanitarian Change. And she's currently working as an independent consultant. Then lastly, we have Alessandro Llamo. I mentioned he's with the TechRRT. He's the IYCF-E advisor. He comes with more than 15 years of experience supporting governments, international organizations, civil society at national and subnational levels and strengthening their support to improve IYCF and maternal and infant and young child nutrition practices, both in development and emergency contexts. He's got extensive experience supporting countries in the Middle East and Africa and South and Southeast Asia, as well as in the Pacific. He has been providing recently country and remote level support to emergencies such as the Syria response, South Sudan, and in Jordan to support the refugees, as well as in Northeast Nigeria and the Philippines. Okay, so the next slide, please. Before we go further, if you're wondering why is the TechRRT hosting this webinar, what do we have to do with it? The TechRRT is a rapid response mechanism to support collective work for nutrition emergencies. It's a consortium that's led by International Medical Corps with Action Against Hunger and Save the Children as partners. We have funding from USAID, OFTA, and we work in close collaboration with the Global Nutrition Cluster and UNICEF. Our objectives are to improve the overall emergency nutrition response, and we do that by deploying technical advisors and as well as providing technical remote support. We also do have, during non-deployment time, we aim to advance each of the technical areas that we work in, supporting global, regional, country-level initiatives. That's part of what this webinar is about. We have advisors that work in CMAM, so community-based management of acute malnutrition, in infant young child feeding in emergencies, in social behavior change, and in assessments for nutrition. So for the infant and young child feeding in emergencies advisor, in general, we're trying to advance that work, and part of it we had wanted to work in line with this year's World Alliance for Breastfeeding Action. They have began a journey to achieve the Sustainable Development Goals by linking each of the goals to breastfeeding. But we cannot achieve sustainable development without multi-level partnership at all levels. Therefore, there's been more work this year about working together for common good, and our webinar has come out of that call for action. So now I would like to move on to our first presentation. Can you go to the next slide, please? Okay, so this the first one is going to be Dr. Shogo Kubota, and I'll stop talking and hand over. And I'm going to switch to share my screen, and then we'll be with you in just a minute. He's going to be presenting on maternal and child health and infant and young child feeding. Just a moment. Okay, can you stop sharing your screen, Edith? Mine is not allowing. Okay, now I should be able to. Just a minute. Okay, bear with me just a second. Okay. Just a minute, sorry. Okay, before we go on, can everybody see my screen? Can you see lessons from implementation of National Strategy on Integrated RM and CH in Lao?
Yes, we do.
Great, fantastic. Okay, great. Now I am going to hand over to you, Dr. Shogo.
Okay, thank you, Andy. You hear me?
Yes, I can hear you well.
Okay, all right. Since you read the title already, next slide, please. Will you go on to the next slide? Yeah. So today I will talk about some of the key indicators in Lao PDR and also national strategy on RM and CH and national nutrition strategy and challenges and some solutions for the integrations of the nutrition into RM and CH and lesson learns, and hopefully we will have some implication to the emergency settings. I will be basically this, as Andy said, since I'm not working right now in emergency settings, and my talk today will be mainly about what we encounter in daily life in this peaceful country, Laos. But I will illustrate some of the challenges and bottlenecks what we encountered or we anticipated and managed to minimize in the process of integrating nutrition interventions and RM and CH interventions, from which I hope we can draw some lessons applicable for the emergency settings. So integration, we give measles shot and wrap that with milk tape while giving health education to mothers. So integration at the point of service delivery can be as simple as that. And still, things like integration, the coordination are haunting us forever. So I would first want to illustrate how this the strategy, RMS strategy and nutrition strategy were developed, and how we had some of the challenges we have encountered in integrating them, and how we solved some of them and not solved some of them. So let's go to the next slide, please. Just some key figures.
Apologies
Andy?
to interrupt. Just I'm here. I'm trying to. Sorry, there. Wait a second. There we go. Okay. There we go. Sorry about that.
That's all right. Okay, so the population, Laos is in Southeast Asia, as many of you might know. It's on the map on the right side, and circled in red. Population of 6.5 million, total fertility rate of 3.2, life expectancy for female, 65, male for 62, MMR 197 per 100,000 live birth, and under 5 mortality rate of 67. And actually, this MMR allows achieved the third most rapid reduction in maternal mortality among the 75 IRG countries around the world. And yet, in this region, still the highest MMR. And this map actually shows the darker orange, the higher MMR, and you can see the Laos, the same color with many of the South Asian countries and also Eastern Africa. Next slide, please. So next slide is the MCH related service coverage. Even though ANC1 is 84%, you can see ANC4, the PNC, the delivery by SBA, and also it doesn't say here about the health facility delivery. They're all around the 50s, and EPI, as you see, it's 70. So you can see it's still quite low. And the second, and the next slide, please. And also for the exclusive breastfeeding, as you can see, as of, I think, sorry, it doesn't say the year, I think it was 2012 or 13. Yeah, the Laos PL is still 26%. It's quite low. And next slide, please. So to tackle these issues, the government has developed this national strategy and action plans for integrated services on RMNCH 2016 for 10 years. So it's launched last year, and it's an action for 10 years. And the next slide, please. And in this strategy, I just copied and pasted one page, which is on a conceptual framework. And if you see the vertical bars, there are 7 bars starting from reproductive health, safe delivery, emergency obstetric care, newborn care, the child care, immunization, and nutrition. These are the 7 areas that this strategy formulated with. And also on the horizontal orange bars, you can see cross-cutting health system components. And with these 7 technical areas and also 4 health system components, except for the governance here, there are 11 strategic objectives. And subcommittees.
Dr. Shogo, just to go back to some, I think we lost you for just about 30 seconds. So perhaps you can just repeat the last thing you said. Yes.
Okay.
Please.
30 seconds. What was I talking? So there are 7 technical areas and 4 health system components. With this together, 11. There are 11 subcommittees who are working on this strategy implementation. So it's quite a huge, with this 11 subcommittees, there are about almost more than 100 government staff involved as enrolled in this committee. So it's a huge mechanism. And as you can see, the breastfeeding and IYCF is also in nutrition component. You see the supply. So these are the priority areas in this each subcommittee. And the next slide shows national nutrition strategy. And in the same year, the national nutrition strategy was developed. And please look at the top strategic direction 1, which are mainly related to health. And I pulled out the 14 interventions listed in this strategic direction 1 on the right side, and yellow ones are the ones, most of the direct service provision. can occur through existing delivery platform of RMNCH, such as the EPI, outreach services, and CEPNC, and so on. And so the two national strategic documents have many areas of overlap, and the overlap itself is not a problem, because each of them has the area of focus, and some of which can be in common. But the challenge comes how we can actually coordinate and integrate. And the next slide, please. So I have put those services on the 14 some of the 14 services on the top of the existing delivery platform. And for example, we can see newborn care. There's already
Hello, Dr. Shogo.
and
Hello,
continues.
Dr. Shogo.
Yes.
We lost you, when you said, for example, newborn care.
Again.
Yes.
All right. So it wasn't too long. Okay.
No.
So sorry about that. So if you see an example of newborn care, the early essential, initiation of breastfeeding is introduced through early essential newborn care and continued to breastfeeding counseling and PNC, and then picked up by IYCF in community. So there is a continuum of care, and these, and also, for example, childcare and EPI also is a good platform for deworming and vitamin A, I guess, in many other countries. So it sounds simple, but of course we encounter some of the challenges. And now I would like to talk about, next slide please, some of the challenges that we encountered and also the solutions. Next. Yes, please, thanks. So, so I will start from what went well. It's an input level of intervention in implementation. As I mentioned, these two strategies were developed in the same time, in the same year. So we could encourage them to communicate closely throughout the development of this development process and to ensure alignment. And this diagram shows where the RMNCH strategy sits, and also nutrition strategy.
Hello, Dr. Shogo.
And also the next.
Dr. Shogo, we lost you again.
Yeah.
We lost you when you said it shows where the two strategies sit.
Right. Okay. I'm sorry. I'm still in the office. I thought this was the best place for a network, but seems it's not too good. So as this document, the diagram shows, it shows both where the two strategy documents sits among other policy documents, and also great. The other diagram you just showed shows how you can integrate. For example, on the bottom you can see community based intervention, how these different areas can be integrated into one delivery platform. So, and also not only the policy context, but also M&E framework or the indicators were aligned along the way of developing these strategies. And next, please. Yes. Another thing that we have to consider, this was a bit more challenging, was the funding flow and pooling. So, even though in the framework we said, okay, these services need to be provided together. If the funding comes in a different timing or from different place or come to a different people, then this integrated service provision becomes very challenging. So we look at how the funding flows in this country, and find a entry point where we can integrate or at least align or the funding mechanisms. And what this shows, MOF, you see the Ministry of Finance gives out money, some fund to MOH, the Ministry of Health, and also down to the provincial treasurer. So provincial governors hold some money, and also each line ministry holds some money, which both goes to provincial health office and also district health office, and goes down to health centers. And also some of the developing partners are funding directly to the provincial or district or even to the community, as you see. And please click one more. Yes. So from this diagram, you can see if the provincial health office, if you focus on this one, there's money coming from provincial governor, money coming from line ministry, the Ministry of Health, and money coming from development partners. But this will output together. So once even though we cannot integrate all this money flow, by strengthening the capacity of the provincial health office in integrated planning, we can try to manage this budgeting, the funding flow, and actually provide a service in an integrated manner using these different fund resources. So that's how we tried. And to some extent, we succeed to manage the funding flow in favor of integrated service provision. Next slide, please. 3 more slides. Maybe I'm a bit over time. So this was a challenge, which we still have as a challenge. The last two about the policy documents, the framework, and also about the budgeting, it's more about the input. And this is more about the process level of the implementation, the challenges in the actual service delivery. So what happened? As you see, MOH has a National Nutrition Center, which has about 20 staff, and MCH Center has about 30 staff. But if you go down to Provincial Health Office, there is no nutrition unit. There's only MCH unit, which has about 5 to 6 staff, and then district level, 3 staffs about, and then down to the health centers, altogether 4 staff. So that's all they have. And yet, because of this huge money fund is streaming into the area of nutrition, in the central level, they have established this nutrition coordination committee. The coordination, it sounds good, huh? But the reality is that in the human resource, there was, in the subnational level, there was no human resource who can actually absorb this fund and also the mechanism that was created in a national level. And I think this is a good example to show the importance of starting the designing of the coordination mechanism from the point of delivery for the realistic design, more than starting from top. Even though, yes, when we talk about coordination, we need a lot of things that has to be done in the top, but that has to be designed according to what they can actually deliver, how they are delivering. And also one thing that I just bullet points here is the last bullet point, the
Hello, Dr. Shogo.
designing the integrated outreach stuff. Yes. Yeah.
Just we've lost you again, and I think we lost you
Yeah,
just as you were about to say the most important.
All right. Okay. Did you hear what I said? Minimize the burden of reporting. Did I start talking about reporting?
No, you hadn't started yet. You were talking about design in line with what they can deliver, and then you had gone on a little bit and wanted to highlight a point.
Okay, so I think I said the Nutrition Coordination Committee, which was developed in a huge coordination committee developed in a national level, was actually burdened, and it was way too much than the absorptive capacity in the subnational level. And this is a good example to show the importance of starting designing the coordination mechanism from the point of delivery in a realistic way. And one more thing, as adding point, is minimize the burden of delivery.
Yeah. We missed it again. Minimize the burden of reporting. I heard you say minimize burden. I think you were going to say reporting.
Yes. Right. So what happens is that nutrition. Let's do MUAC. Let's do monitoring, the growth monitoring. Since they're going down to villages, the EPI people are going down to the village. When they do immunization, why don't we do the MUAC and put all these interventions in nutrition? That's a good idea. We can do this. But what's the issue? What happened is that because they have different reporting forms, even though the service itself for all the nutrition and immunization together, it takes 1 minute for one child, but recording this took 3 minutes. So that's also a small thing, but when we talk about integration, we really need to put ourselves in the position of the people who are actually giving the service, recording the service provision, and see how we can minimize the burden in this integrated process. So the next slide, right, please. So this is second to last is the lessons learned. So next slide. Yes, thank you. So being aware of potential obstacles, the challenges to integration in each process of implementation will help us to design a realistic coordinated service provision. In the input level, this is kind of a summary, but input level, the policy and the framework and the M&E framework also, and also the framework of service delivery, as well as funding flow and pooling can be well considered when we try to integrate things. And also for the process, the management and organizational structure and guidelines and training.
Hello, Dr. Shogo.
And these things we can, yeah.
Okay. We lost you from guidelines and training.
All right. So this input process outputs a different stage of kind of potential obstacles. And when we plan this to make sure these are all aligned, I think one important thing is that we plan from the bottom up. First, we imagine and have a clear and common picture of how it looks like in a point of delivery, and then walk upwards. And I think this is, I understand the situation described here is very different from the field most of you are working in. But I hope this will give some of the example of this structured planning in terms of integration in a realistic integration planning. And the last slide as a conclusion, back to mother and child-centered care. It sounds paradoxical, but terms like multisectoral or integrations are actually the terms from our perspectives. And as a pediatrician, I simply do what the child in front of me needs. And only when I started working in a public health, I started talking about multisectoral and integration and coordination. So I think even when we design a bigger picture, the point of delivery is where we need to start to design this coordination mechanism. Back to mother and child-centered care. That was the conclusion of this talk. Thank you very much.
Wonderful. Thank you so much, Dr. Shogo. That was very interesting. I appreciate that. I think it's clear, just 1 second, how we, just a second. I'm trying to show my screen properly, but My taskbar is here, so I cannot. A moment. Oh, wait. Normally I do it from the bottom, not from here. Just a moment. Hang on. Oh, I can't get to it. This is not good. There we go. Okay, just a second. Okay, thank you so much, Dr. Shogo. I think that was very interesting. And while we obviously your situation is not an emergency context, but I think that you've highlighted quite a number of things that are important and the reality for people in emergency settings to take into consideration. We'll talk about those more a little bit at the end. I'll highlight some of those when after the other presenters. So now we'd like to go to Erin McCluskey Rebelo, who will be talking WASH and infant and young child feeding. Erin, are you ready?
Yep.
Great. Just a moment, because I still have this problem with getting to the bottom of my screen. Just a second. Got it. Okay. Everyone, can you see it now?
Yeah, but it looks kind of funny.
Maybe it.
That's good, Andy. Yeah.
Okay. All right. Great.
Okay. So you can hear me okay?
Yep, perfectly. Thank you.
Okay. So as Andy said, my name is Erin, and I have a ridiculous last name, so let's not worry about it. And I'll be talking about integrating WASH and IYCF, focusing a little bit on emergencies. I have worked with several NGOs and then into UNICEF, as Andy said, and most recently, the most recent relevant experience is working on this toolkit. Can you go to the next slide, please? So with the Center for Humanitarian Change, I worked on the Synergized WASH and Nutrition Programming Toolkit for the East and Southern Africa office. And this is the front page and the website where you can access it if you're interested. As you can see, it's not on the UNICEF webpage, because if you've worked with UNICEF before, you know that things don't happen quickly, and I don't believe that they've actually diffused it yet. So it remains sort of embedded in the center's website for now. And I think it's important, this toolkit is interesting. It has quite a lot of tools and resources for advocacy and fundraising, for HR, for planning and coordination. And it does have specificities for UNICEF, but it has also quite a lot of resources that were designed to be used with a wide variety of stakeholders. With respect to this, it's also, I think, really important to note that it's not just UNICEF in the region in which I sit, which is Kenya and Africa, but UNICEF in other regions is producing similar guidelines. And also I'm sure, as you know, there are a number of NGOs like ACF who have also recently produced similar documents. So it's coming up as a very important topic for people, which I think is great. You can go to the next slide. Before we talk about what to do, I think it's important to understand why we're trying to do some things. So why are we trying to integrate WASH into nutrition and into IYCF? And this is a diagram adapted from an article by Chasen and Guri, and I really like it because I think it very clearly shows the quite short pathways whereby WASH practices affect nutrition. And my very limited IT skills. If you press forward, maybe it shows. Yeah, so that's, sorry, I'm ridiculous with IT. So in the top half, it's a lot about the direct pathways, I think, with diarrhea, with the enteric infection, and with the worm infestations leading to undernutrition. And then if you go forward, Eddie. In the bottom half, it's more about the indirect pathways with respect to time poverty and the costs associated. And For IYCF behaviors, you're looking at, as I'm sure you understand, both the direct and indirect pathways, whereby WASH practices very clearly will affect how children are growing and evolving. So you can go forward, Andy. Okay, this is one of my most favorite diagrams. It's so clear, the correlation between episodes of diarrhea and stunting. We just can't get anywhere with nutrition, and we're not going to get very far with IYCF if we're not looking at WASH. And this is not a one-off. This is data pooled from 9 studies over 20 years in 5 different countries. So it's so clear, and it's affecting stunting. And as you know, stunting has all kinds of long-term developmental effects in kids. And so we're not, as I say, we're not going to get anywhere if we don't start working on diarrhea and WASH. And if you can go forward again, Andy. And this is also something that's very important. I'm sure you've heard, if you're a nutritionist especially, about tropical enteropathy or environmental enteropathy or enteric infection. It's all sort of the same thing. And it's all about how there's intestinal inflammation due to this persistent exposure to feces. And it's really about animal feces. And it's because the guts of animals are a lot more mature evolutionarily than ours, and so it affects our and digestive systems in very bad ways. And as you can see, the top is a healthy gut, a healthy intestine, and in the bottom we have an intestine that has this infection. And it's really critical because it's actually, for the most part, a subclinical infection, meaning that diarrhea, we know when a child has diarrhea. This is subclinical, meaning that someone will not necessarily exhibit the signs. But in the bottom intestine, that intestine is not absorbing nutrients properly, and at the same time, it has an increased permeability to infectious agents. So it's prevalent, I strongly believe, and I think it has a very important effect on nutrition. And what's critical about this is 2 things. The first of all is that it's the youngest children, so the children under 2, that are most affected because they are closest to the ground. They have a lot of hand-to-mouth behavior with respect to their environment. And it's also a lot about animal feces. And when we talk about WASH, we don't actually often address animal feces. We normally address disposing of human feces properly. And so I think there's a lot that we need to start doing in order to achieve our goals. You can go forward, Andy. I'm not going to read this slide. The important part of this slide is that it's just a note that while there's quite a lot of good evidence connecting poor WASH practices with poor nutrition outcomes, there isn't a significant body of evidence yet that very clearly tells us what are the key WASH interventions that improve nutrition outcomes. So while for me it's very intuitive, a lot of people need, scientific studies, and they could be donors, they could be your boss, I have no idea, but it is important to mention that these studies aren't there yet. There are a number of ones coming up. There's the SHINE trial in Zimbabwe, there's WASH benefits in Kenya and Bangladesh, and there's been MAPSAN in Maputo and Mozambique. And so this body of evidence is growing. Go ahead. But as I say, for me, if you look at that pathways diagram, we all know more or less how to break a fecal barrier. So I have a lot of trouble believing that we cannot just sit as professionals together and find some entry points and find some activities. So I don't actually think it's about the what, I think it's a lot more about the how. And when we did this toolkit, I interviewed 15 or 16 UNICEF country teams in Africa, and these are the WASH and nutrition departments. And we were interviewing them about what their key challenges for integrating WASH and nutrition are. And everyone started telling us they weren't really sure what to do. And when we probed down and probed down and probed down, we found that they really they did know what to do, but institutionally, they were unable to integrate properly. And if you can go to the next slide. So from those interviews and from the literature review, we found that one of the key ones was limited staff time, capacity, and interest. And this is a really big one, especially in emergencies. I worked for UNICEF during the famine in Somalia, and I was supposed to be the IYCF person, and we were completely unable to implement almost anything to do with IYCF. And it had to do with staff time at a management level, and it had to do with staff capacities in the field. And so I think this is something critical, unless we address this and provide some authority and more, generating more interest, we're not going to get there. Sorry, you can go ahead to the next point. There's also, if you're talking about working cross-sectorally, and maybe this isn't so important in NGOs, but it's important when you're in a big bureaucratic agency like UNICEF, you can have siloed funding and you can have uncoordinated funding cycles between those departments, which really doesn't promote integration. Go ahead. No? Mm-hmm. Oh, sorry, limited knowledge of other sectors. That's quite self-evident. Go ahead. Lack of evidence, as I said, it's there. For me, it's not important, but for some people, it is important. So there's also this one, sorry, go ahead. That's not really an important one right now. Go ahead, Andy. Lack of accountability and coordination structures. This is actually quite an important one as well, because if you're talking about a coordinated action, it wasn't always clear, and maybe this is, specific to a UN agency who has to work with the government, but who's responsible for those actions? It's in order for things, it wasn't clear if the nutrition program is implementing, is the WASH program implementing, who are you reporting to, who's going to coordinate it? Go ahead. Uncoordinated government ministries. The nutrition department, is it in the health department? Is it outside the health department? Sometimes WASH is actually also split into several different ministries, and it's very hard to coordinate. Go ahead. That might be it. Oh, difficulty in monitoring other outcome areas. Yeah, this is, that's also quite evident, I think. You can go to the next slide. So where to start? I think obviously for me, it's what's the point? So you go back to that pathways diagram or whatever you're trying to achieve. What are you trying to do? What are you trying to stop? Are you going to work on diarrhea? Are you going to work on all the fecal oral routes? Are you going to work on time? What's the point? And it has to be risk informed. What are the key WASH risks for the group you're looking at? Is it the 1,000 days? Is it kids under 2? Why is that group specifically vulnerable, and start to work out from there. Go ahead. Obviously, what are the pathways most relevant to your context and your program? Go ahead. So bear in mind the nature of the emergency and the programs involved, especially as I'm sure you've all worked in emergencies. It's very difficult to set up new infrastructure, new supply systems, train new staff in the middle of an emergency. So can you use existing entry points? Can you start working together in existing IYCF programs and existing WASH programs, OTPs, whatever? Go ahead. Staff being overwhelmed in an emergency. For me, I felt this, it was really important. You need to look at your quick wins so you can get started, and then you can start from there, introduce maybe new programs, look at more longer term things, but I think for some immediate gains, look at what can be quickly and easily implemented. Go ahead. Realistic reporting requirements, so important. When I was at UNICEF during the famine, we spent way too much time reporting and less time on quality, because it was required by headquarters, it was required by donors, it was required by media. And I think if you're managing an emergency response, be very clear, especially if you're introducing a new element, what is the information you're going to use? Otherwise, don't ask for it. Go ahead. And for those endemic and cyclical emergencies, you know, the droughts, the floods, the AWD and cholera, these things come back and they come back and they come back, and there's so much prep work that can be done before. So we have to start looking at what are the shocks or the stresses we're getting quite a bit. How can we start making programs shock responsive before they hit? Go ahead. Okay, I don't know why I put that here. I can't remember, so you can just go forward, Andy. So what are some examples of shock responsive IYCF programming? This is not an exhaustive list. These are just some things that I have personally done. So it's just, you know, the beginning of examples, I would say. So obviously targeted messaging. If you're having an AWD cholera crisis, what are you going to focus on? Refeeding after illness, water treatment, food hygiene, you know, be specific to the emergency. Go ahead. You can, if you're having an AWD crisis, or if you're going into a season where you always have an AWD crisis, consider DTKs, diarrhea treatment kits. You know, it's often 10 tablets of zinc, 2 packs of ORS. Start distributing them to the households and the areas where people are vulnerable. And instead of having to seek treatment after the diarrhea, which could be days after, if the mom's busy, if she can't get the cash, if she's not close to a health facility, consider doing it beforehand and get those packs out where they're needed. Or water purification. You can also do wash products for young children and their families. PSI was doing this in Somaliland in their regular program, and kind of an IYCF program. They were distributing wash products so people could practice the behaviors. There's wash hardware for IYCF programming sites. That's quite clear. Go ahead. And so when we were working on the toolkit as well, everyone was very clear about how nutrition should shift to accommodate wash. What was less clear was how wash should shift to accommodate nutrition. And there is this problem of hardware, software in wash. You have engineers who are, I'm not going to go into that, but you know, they're less visionary in terms of some of these things, I would say. So that's something to think about. Go ahead. But if you have multi-use water systems, they're more flexible with how people can access that water. Go ahead. You can target emergency hardware at focused 2 key groups. So is there a site where you know that women are more able to access water for their small children? Is it convenient? Is it, you know, all these gender sensitive? Integrated messaging, again, that's clear. Go ahead. I feel like I'm running out of time, Andy. You're clicking. Wash contacts. So this isn't, you know, you can give wash contacts, those who are in the communities, you can give them a list of nutrition sites and IYCF groups and a list of characteristics they should look for in order to pass that information along. And then for the next point, you can also give them UAC tapes, distribute them, train them how to use them. It's so simple. You can go to the next slide, Andy. And then for shock responsive OTP, guidance note for nutrition sites and IYCF support groups during AWD and cholera outbreaks. I know that WHO has just released their SAM and cholera guidelines, I think. Wash discharge kits for OTPs. And then the last point is, and what we supported in Somalia was follow-up of AWD patients identified at nutrition sites, which helped. Okay, you can go to the next slide, Andy, which I think is my last slide. So Baby Wash, I'm sure you all heard about Baby Wash. That's the coalition website. It's a multi-agency partnership. IMC and ACF are among their. Baby Wash is a really nice integration of IYCF and WASH. So it's targeting pregnancy, labor, delivery, newborn, the onset of feeding, and the onset of mobility. Go ahead. Some of the key actions are separation of young children and animals, hygiene play areas. So that's breaking the young child and animal fecal contact. Go ahead. Safe cleaning, storage of feeding and cooking utensils. And hand washing, the next one. Hand washing, obviously, and including after caring for animals, which is often not included. And then obviously hydrating during complementary feeding. And the last one I think is safe wash in healthcare facilities. So those are just some idea of some of the actions. So that, I think, brings me to the end of my presentation. I hope I didn't talk too fast. Thank you very much. And just to say that I bombarded Andy with some resources. So if you're interested in learning more, you can harass her for the big file.
Wonderful. Thank you so much, Erin. It was really interesting. And yes, everyone, if you want more resources, I'm happy to share what Erin has shared with me. So just drop me an email using the same one that you used before, or that you got the joining instructions from. Okay, I'm very conscious of the time as it's already now just gone the hour. So I'm going to go into our next speaker, if I can get my slides to move. Okay, which is, yeah. Oh, I didn't change it properly. So it's not maternal and child health and infant and young child feeding. It's actually infant and young child feeding with Alessandro Llamo, our advisor. Alessandro, are you ready?
Yes, very ready.
Okay,
Thank you,
let me just
everyone.
find
Yep.
your slides. Go ahead.
Can you hear me well?
Okay. I can.
Great.
So I assume everyone else
Yes.
can. Good. Okay.
Let's start then. First slide, please.
Do you see it? I've put it up. I hope you have
so
it.
we start. Yeah, I can see. Yeah. Can I start now?
Ed.
Yeah, so there is a controversial question. Is IYCF in emergency still a win-win for all or not anymore? We will find out and discuss a bit later. Next, please. So what do we know? And this is, I think, is our first starting point. And I believe we all know a lot. We know that improving breastfeeding has been proven once again to save lives. And the majority of these lives are those lost within the first 6 months of age. We know that breastfeeding, please go on, go back to the next slide. Please move next slide, please.
I think we're having a disjoin between Vientiane and Spain. Apologies.
I am in Phnom Penh. Okay.
Oh, sorry. I'm sorry, of course.
So we have evidence about how breastfeeding can prevents mortality, but as well very strong evidence recently published about breastfeeding and preventing morbidity in terms of episodes of diarrhea, respiratory infections, and incredible the number of admissions, the percentage of admissions, hospital admissions that can be prevented as well for diarrhea and respiratory infections. We know, and there is much more evidence that supports the importance of breastfeeding promotion, protection, and support. Next, please. We also know what works. Again, systematic reviews of more than 20,000 peer-reviewed articles are telling us that breastfeeding practices can be improved when they are delivered in multiple settings like health systems, communities, households. We also know that the largest effects, the largest improvements are due when these interventions are delivered in a combined fashion, and the combination varies according to the settings, trends, and context. Next, please. And again, I believe the audience of the participants of this webinar knows very well what we are supposed to do during emergencies. Continue, protect, promote and support optimal IYCF practices, look especially after our non-breastfed infants, manage infant formula donations, prevent it as much as possible, and look at appropriate complementary feeding as well as taking care of the mothers and the caregivers. We all know this. Next. But what do we experience? And I will just go through some of the key emergency, or some of the emergency we have been working on IYCF-E, and some of the issues and challenges that we've been experiencing as humanitarian workers. Next, please. Iraq 2000. Yeah, I am getting it with a bit of delay. That's why I want to make sure it's there. So Iraq 2003, there has been a huge, a study shows that there was a big increment of infant formula distribution between 1997 and 2003. We're talking about 14 years ago. And as you can see, there was a high percentage of bottle-fed infants already that between 2003 and 1996 was about 25 to 30% of increase. And that deteriorated further the exclusive breastfeeding rates in the country or in that particular region. What was also very interesting from this health and nutrition assessment was that majority of the cases, some cases, were actually using formula either fully or partially. Next, please.
Hello.
Yeah, I think I will go with my slides. I don't see yours appearing. Just tell me if I'm aligned with yours. When we look at Botswana, it was an HIV-related experience wherein 30% of formula-fed babies died in an hospital setting, and none of these were breastfed. This is an highlight of a study that was published in 2006. Next, please. Indonesia, in 2006, we are all familiar about the uncontrolled distribution of infant formula and powdered milk and the disastrous effect that it had on the population that received such donations, with a documented increase of 5 times of diarrhea incidence post-earthquake. Next, please. Another experience of IYCF-E in terms of challenges has been Lebanon in 2006, and once again, fears of unregulated distribution of infant formula were unfortunately translated into reality with deterioration of key breastfeeding practices, as you can see from the table. Next. Philippines 2013, we have a very strong policy. We had a very strong policy and some form of quite good compliance on the no donation of BMS. But again, the challenge was how the public opinion was divided around this. And humanitarian workers, both in the UN and in the INGOs, were receiving text messages, SMS messages, calling for us as killers of babies, enforcing such policies in a time of disasters, in a time of emergencies, or how children were suffering and eventually were becoming malnourished because of such policies enforcement. Next, please. Or let's look at Syria 2016. Once again, as we all know, widespread donations of breast milk substitutes, very limited coverage of services. In qualitative studies, more than 90 online campaigns calling for donation. Most of these campaigns were actually initiated by national NGOs. And when you look at coverage of services, only less than 10% of the affected population was actually reached by some form of IYCF support, IYCF-E support. Next. And if we take an example, country X, just in currently facing a major emergencies, well, we see how even the conflicts between public health priorities are challenging our IYCF-E interventions, like milk powder is being distributed as an incentive, no, to increase coverage on mass immunization campaigns. But also at the same time, we see how alarming is the situation when we look at 70 to 90% of children admitted, enrolled in the CMAN program are actually under the age of 2. And we can explain this partially looking at the IYCF practices in place. Exclusive breastfeeding was extremely low, and minimal acceptable diet was basically not existing. No? And again, coverage of IYCF-E services limited to 10 or even less percent of the affected population. So what are the challenges in general? No? We have seen some of the experiences that we keep facing years after years, emergency after emergencies. Save the Children conducted a review of global gaps and challenges in 2012, and I highlighted 2 of their key findings that I think we feel they are very relevant even nowadays, despite the 5 years gap between the review and today, no? And they confirmed that IYCF-E programming has demonstrated till that time gaps in aligning with the international recommendations and the standards and working at scale. And also how IYCF-E was not, and I think until today, is not seen as a life-saving intervention during these emergencies. So funding, political support, prioritization, and all the rest are certainly lacking or not there, not yet visible when we intervene on the ground. Next, please. And other challenges, there was a systematic review just recent in 2015 that shows a systematic review of researches on health interventions and their impact in humanitarian crises. Well, only 4 of the 77 that were included, that met the inclusion criteria, were actually focusing on IYCF-E. That shows also some of the limitations of our documentations, information management, data system, indicators, and all of the above. No? And again, as I was able to show in some of these experiences that I presented, limited coverage of interventions, sometimes no systematic and strategic approach in the way we intervene. And let me say, and this is based on personal experience, of course, disconnect even within the nutrition program, if not only with the other sectors. And thinking loud, maybe we could look at Haiti 2010 as a model for an intervention scale. This is something for discussion. And I would like to go back and emphasize one of our weaknesses, the few limited documentation and poor and weak data management systems that supports IYCF-E. And this is due to few confusing data, indicators that are not standard, clear, or not used in a standard way, and certainly not used to inform programming, not just within the nutrition arena, but also outside. And let me say this again for direct experience, poor narrative supporting our IYCF-E, no? And there is some form of recognition due to the evidence we have, but very much little is done to translate this recognition into actions and prioritization. Next, please. But if I was putting a question mark at the title at the start, is it a win-to-win? I fully believe it is a win-to-win through convergence, through integration, and through synergy. And these are three different dimensions, but wherein IYCF-E is a win-win situation for all. Next. And maybe it's because we need to look at it not on a vertical level, not as one of the many other sectors or programs, but because we need to look at IYCF-E as a cross-sectoral intervention. And basically is looking at how IYCF-E is actually contributing to the different sectors' achievement of their objectives and mandate. So it's more a mean to them in achieving their goals. And at least this is the way we should, I think, look at IYCF-E and how we implement it on the ground. So what can we actually do? This is just a short list of concrete actions that I would like to recommend and discuss with you all. Let's think scale, let's reach scale. I think we should look at IYCF-E, and this has to be reflected in not only in the nutrition cluster or sector, but in any SRP, strategic response plans, and other strategy settings documents. Let's do our own work. Let's understand what the stakeholders of the different sectors, even within the nutrition. And again, I would like to emphasize it. Let's start within our own house and aim for an integrated package of quality services. My colleagues have provided some concrete example. We have to engage. There is nothing to do. We have to be on the forefront, engaging management and emergency coordination teams to look after policy coherence among sectors. I showed the example of obvious conflict between public health priorities in one of the countries. And this is through advocacies, representation, joint statements, and commitments, but basically engagement on the front line is a must if we want to bring IYCF-E higher in the agenda. And let's bring forward key, concrete, but also realistic proposals that can enhance the sector we are facing objectives and mandate. And again, some examples were given, I won't repeat them, but this is what we need to be able to discipline ourselves. Let's propose what is concrete and realistic on the ground. What else can we do? It's certainly a clear in our mind a minimum package of interventions, minimum that will help achieve our goals of protection, promotion, and support. Let's propose IYCF-specific interventions that are, again, are relevant to the sectors. I think this is key to gain their buy-in. And let's, again, I will use the term discipline ourselves to 2-3 concrete outcome program and outcome indicators that can inform sector and sectors and guide their programming, both in terms of information and assessment, in terms of assessment, but also in terms of recording and reporting. And I really appreciated the comment of Dr. Shogo on the importance of being realistic on this. Next. So conclusion, I think there is no doubt that we all believe that IYCF-E is a fundamental mean if we want to prevent morbidity, mortality, and malnutrition, more so even during emergencies. I think there is no doubt, and our colleague on WASH has expressed it very clearly, that we have several and multiple opportunities to integrate IYCF-E within the other sectors. There is also no doubt if we know how to package it, we know how to present it, then it's certainly a win-win for all. Every sector gains out of IYCF as a mean, as a vehicle for their programs and interventions. Let's also be realistic. Again, I think there is really much we need to do to transform IYCF-E into from a vertical as it perceived today, as it can be perceived today, to a cross-cutting and cross-sectoral program. Let's certainly prevent it to become or to be seen as a vertical and exclusive intervention. Much has to be done if we want to achieve policy coherence across sectors and among agencies. It's a work still in progress. And again, I think we should agree that there is still a limited investment and resources on IYCF-E in terms of surveillance and data management, and we are suffering because of that. And some controversial statement, but maybe just to stimulate our discussion. Is it really possible for us to implement IYCF-E at scale? Are we capable of doing that? We fear that integration of IYCF in other sectors is actually a way of watering it down, or watering its message down, or its effectiveness. Are we saying that IYCF-E documentation, information management, or research on its effectiveness is not really of concern or not really a priority where we need to focus? Or are we also in agreement with those that says that during an emergency response, yes, IYCF-E is important, but is not an immediate concern. It should come in later. Let's focus on OTP and CMAN. And again, policy coherence during an emergency is not of concern. Are we in agreement with that? Because our key is reach what our outcomes, our targets and goals. So get all of the children immunized first, and then we can discuss about policies and their implementation. And with this, I think I end, and happy breastfeeding week, everyone.
Thank you very much, Alex. Very interesting as well. Now how to summarize between all of your very interesting presentations. Okay, so let me just go back here. Okay, so now just to come to our wrap up. Basically, we've heard a lot, and we've heard from Dr. Shogo about integrating how they've made nutrition, well, breastfeeding and infant and young child feeding really a part of the health strategy and integrating into their normal business, what it should be, looking at a child first, child and a mother pair to see how to deliver interventions. We've heard across between Dr. Shogo and from Erin and from Alex, we've heard some things that have been repeating between the three of them. One of which is interesting to hear that even in Laos, which is not in an emergency situation, on the ground at a local level, there's still a vast deficit of staff to implement activities. So we have to be realistic in what we can do. That doesn't mean we shouldn't try to do things and we shouldn't try to do them at scale. We just need to be strategic in what we're trying to do. We've seen very clearly from Erin on WASH and how closely and how important it is, how closely related and linked nutrition is to episodes of diarrhea, and we know how much of an impact breastfeeding and infant young child feeding interventions can have on reducing diarrhea. We see our health structures are totally overstretched, whether it be an emergency or not, and even worse so in an emergency. So we need to choose those quick wins that are really going to be easy for them to implement, and we need to actually ask for what is actually going to have the biggest impact. As Dr. Shogo very well, that we need to design in line with what they can deliver, and that we need to have we need to start with that child mother pair and what they need, and start and from there design a clear and common picture at the point of delivery of what we want to deliver. So do what the child in front, the phrase that Dr. Shogo said, do what the child in front of me needs. So look at the child as a whole. Let's not think about the sectors. Let's think about how that child who is experiencing diarrhea, not just how to treat it, but actually how to prevent it, and prevent it for his sisters and his his brothers and his neighbors. That we need to actually start designing from the bottom up, so that we're not being unrealistic about what people can do, but from the bottom up, not just in location, but in lots of locations across the board. Erin highlighted very clearly again about limited staff time, both at the management level and at the local level, but also a capacity gap at the field level. We need to design our programs in reality of how the program will be implemented and the people that are going to implement it. We don't want to overwhelm them more. So we need to be realistic in our reporting requirements. That was echoed by all of our three presenters. We also need to do more in preparing for programs, as during non-emergency times, a lot of these things can be put into place before an emergency actually hits. And we need to actually look at this, as both Erin and Dr. Shogo said, you look at the child in front of you. As Erin put it, shock responsive. We need targeted messages that are going so that you know what you need to focus on that's going to make a difference with the population that you're working with. Then, as Alex highlighted, quite a lot of situations where we've had potentially good intentions that have gone astray. We need to remember in emergencies to do no harm. We have to be talking sitting all together to try to make sure with our closest colleagues that they're not doing something that's actually going to harm a child even more. We have a very, very good examples of some vertical programming that have had potentially very negative impacts on our children and their breastfeeding practices, and therefore their potential risk of illness, etc., and death. We need to be working across sectors. We need to find those concrete actions, realistic ones, that can be done to bring a real change to children facing emergencies. While we need to make sure that our reporting is within realistic possibility for the staff on the ground that are going to have to do it, we also have to remember that we do need to figure out how to watch the situation and monitor it, because if we're not able to monitor it and follow the situation, we aren't going to be able to see that in fact that distribution of infant formula actually had a negative impact on the diarrheal level of children in X or Y or Z emergency. Okay, with that, I'm going to stop talking. I think there's a lot of important points that have been brought up. I encourage everyone to go ahead and write any questions, or feel free to speak. We're happy to hear other voices. I am conscious of the time, so maybe we just take a few more minutes for some discussion. But before we do, I also wanted to highlight a couple of tools. One tool that is coming out, I don't think it's quite off the press yet, but should be very, very soon, is the IYCF-E Friendly Framework. It's been a work in progress between UNHCR and Save the Children, with lots of other partners contributing. You can find it on this website. At the moment, I'm not sure that the framework is up, but it does have a video. I wanted to play it for you today, but it's not going to work with the Blue Jeans connection. But as you see on the screenshot is from the video, emphasizing how, in this case, the woman's name is Sarah, and her baby that are refugees have had to flee from a situation where they were living, and how every sector has had to come together to support her, to be able, her and her baby, to be able to promote, protect, and support their infant and young child feeding. There's also the infant and young child infant feeding in emergencies operational guidance, which is currently under revision. The last version was, I think, from 2007, and it's available from various websites. I can share that with you. I didn't put it up here, but please let me know if you'd like me to share it with you. In addition to the WASH nutrition tools that Erin has highlighted, we have lots of different things we can be pulling upon to try to improve programming. Okay, so now I will stop talking and hand it over to all of you. And I wanted to thank you very much for your participation today. If you want to contact us for any reason, it's here, and I don't know if any questions have come up. I'm going to leave it for just a minute to see. Okay. If we don't have any questions or any discussion, given that we've already been on for an hour and a half, please do, oh wait, there is one question that's just come in. Edith, can I ask you to read it out, please?
Yeah, sure. So the question is from Geraldine, and she was wondering if it will be possible to get a copy offline links to the pathways diagrams that Erin shared in her presentation. Erin, would you be able to send us some links?
Yeah, the diagram is adapted from an article by Chase and Ngure. So she wants the article. I think it might be in the package of things I sent Andy. I'm like 99% positive it is.
Okay, sure. So Andy will make sure that it will be circulated.
Yes, exactly. Okay, fantastic. Okay, if I know it would be wonderful to have more discussion, but it's been we've taken a lot longer than planned. Are there any other questions that have come? I saw some messages pop in.
Yeah, so we just got a question from Ali, Andy, and she would be interested to discussing some of Alessandro's questions at the end of the presentation, and she's happy to chat later if Alex wants more time.
That's great. I will put the two in touch for sure. And if anybody, in fact, if I don't know, there are many other people on the line still, but if anybody else wants to join a further discussion, we're happy to facilitate that. And in fact, probably I'll share post-webinar, I'll share something to suggest that to all. Okay. Anything else, Edith?
No, I think that's it.
Okay, wonderful. Okay, I thank you all for your participation and for your patience with some of our technical difficulties. And I look forward to where we move with this to see what happens next. Hopefully we'll be able to have a follow-on at a later date with some more experiences to share. Thank you.